Hello everyone, I'm Dr. Mousumi Banerjee and I'll be giving a brief insight on block-related complications in ophthalmology. Anesthesia used in ocular surgeries can be either local anesthesia or general anesthesia. Under local anesthesia, it can be topical, intracameral, infiltration, or nerve blocks. Today, we'll be focusing on retrobulbar and peribulbar blocks and the occasional complications associated with them. Now, before we delve into the complications, let's do a quick revision. That in retrobulbar block, the local anesthetic is injected in the intraconal space, whereas in peribulbar block, it's injected in the extraconal space. So, what are the complications that can happen? They are globe perforation, retrobulbar hemorrhage, optic nerve sheath injury, myotoxicity, brainstem anesthesia, and oculocardiac reflex. Now, let's go into the details of each complications one by one. So, what are the signs which can be noted in a case of block-related complication? They can be lid ecchymosis, sudden drop in vision, fixed dilated pupil, rapid rise in intraocular pressure, increasing proptosis, and severe marked pain. This is a case of retrobulbar hemorrhage, which has an incidence of 1 to 3%, and they are mostly venous in origin. So, how do we differentiate between venous origin and arterial origin? In venous origin cases, there will be a very slow spread. In contrary, in arterial origin, there will be a very rapid spread with a very taut orbit and marked proptosis noted. So, how do we manage such a case? Immediate globe pressure has to be given. The intraocular pressure has to be managed with intravenous mannitol and oral acetazolamide, and lateral canthotomy might have to be performed as well in some cases. Now, sometimes the signs might be subtle and they can be detected only during the operation. Just like in this case, where after phacoemulsification, we could see a streak of blood in the vitreous cavity, which increased in magnitude and intensity over the time. So later on, when we performed an indirect ophthalmoscopy, we could see a break due to block, and we had to laser barrage this break. So if penetrating or perforating injury is suspected, stop injecting the anesthetic immediately and withdraw the needle. Do an indirect ophthalmoscopic examination to assess the injury. Once the bleed resolves, LIO of the suspected break has to be done. And the incidence of globe perforation is around 0.47%, with high myopes being one of the major risk factor. So we need to be very careful while giving a block in cases of high myopes. Now, oculocardiac reflex will occur due to mechanical stimulation of the globe. The patient will present with bradycardia, hypotension, ventricular changes like ectopy, and fibrillation. How do we manage such a case? We have to stop the surgical stimulus immediately, ensure ventilation and anesthetic depth. Local injection of lidocaine near the eye muscle has been reported to be beneficial, as well as administration of atropine. Optic nerve sheath injury can happen due to direct needle stick injury to the optic nerve, or due to pressure necrosis from local anesthetic agent or hemorrhage around the optic nerve. Patient will present with marked loss of vision or blindness, and optic atrophy can be noted in later stages. So we need to check and recheck the vision as early as possible in such cases. Surgical decompression and nerve fenestration has been attempted. However, it carries a poor prognosis. Short course of steroids can also be given. Myotoxicity can happen due to direct needle trauma or ischemic pressure necrosis, or direct myotoxic effects of the local anesthetic agent. It has also been associated with high concentration of lidocaine. Patient will present with diplopia, ptosis, or entropion. It's usually a transient phenomena, and inferior rectus is the most common permanently damaged extraocular muscle to be reported. Physiological strengthening of antagonist muscle and small angle deviations have been tried in many cases, especially when there is a permanent damage. Now, coming to a very serious complication, that is brainstem anesthesia. It occurs due to systemic absorption of local anesthetic agent and or puncture of the dural optic nerve sheath and injection of the local anesthetic into the subdural space. Patients will have apnea, cardiac arrest, vomiting, temporary hemiplegia, aphasia, generalized convulsions, and the characteristic feature is palsy of the contralateral third and fourth nerve. The patients can be managed with cardiopulmonary resuscitation and bag and mask ventilation. So young ophthalmologists can read these articles for further clarity and for further in-depth knowledge regarding this complication. I would like to thank the YOSI team for such a wonderful initiative, and I'm very grateful to be a part of it. Thank you so much.